But one of the pros for sure is that we know that these patients are likely to be cured locally, but they tend to have relapse in lymph nodes of the thorax or distant relapse, even after 3-4 years from the stereotactic radiation therapy primary treatment. So we need something as systemic therapy that can improve these results and basically decrease this risk of relapse. However, being these patients quite frail, we cannot apply chemotherapy for sure. The idea of using immunotherapy was very brilliant and very logical. There is a strong rationale in combining radiation with immunotherapy as maintenance. However, the problem is that we have a lot of patients that are going to die not for lung cancer but for other causes, so this may cause some difficulties in interpreting the results, because maybe immunotherapy was working but we lost this patient for other causes, and it is very difficult because there is a competitive risk of that problem. And then there are also some very small tumors are very well cured from stereotactic radiotherapy. And so probably the sample size to detect a difference in distant relapse-free survival would be extremely high, and the studies that I will be presenting were not powered for showing such a small result. So probably there is some benefit but we need better define the subgroups. The cons are the fact that you are giving a medical treatment to patients that are elderly, sometimes unfit, for a long time, because the maintenance is from 12 months to 24 months. Only one study with very positive result, they use 4 cycles only of immunotherapy. I will highlight this study because it's the most positive and it's also the most feasible, the most acceptable for patients.